Hello, you're listening to the latest season of the COVID Inquiry podcast. This week, Nicola is joined by Lorelei King, actor, screenwriter, narrator, and most pertinently, a member of the COVID-19 Bereaved Families for Justice group. Together, they're going to reflect on how the recent hearings went and look forward to the next few days of evidence. Please note, some listeners may find the contents of this podcast distressing.
Hello everyone, I'm Nicola Brook and I'm the solicitor at Broudie Canter with day-to-day responsibility for managing our work on the COVID inquiry on behalf of COVID Bereaved Families for Justice UK. I'm here with my co-host Lorelei King, who is a member of the group having lost her husband to COVID. I am delighted today to be joined by two witnesses who gave evidence this week, Professor J.S. Bamrah and Dr. Cathy Finnis. Professor Bamrah is a senior consultant psychiatrist and gave evidence on behalf of the Federation of Ethnic Minority Healthcare Organisations, and Dr. Cathy Finnis was a medical doctor until the pandemic when she had to leave her face-to-face clinical work due to being severely immunosuppressed. She is also the deputy leader of Clinical Vulnerable Families. Thank you to both of you for joining us today and welcome to our podcast.
Good morning. Thank you both for being here. We're so lucky to have the two witnesses, and thank you for your testimony this week. I wonder if I could talk to each of you about a little bit about what you thought was most important in your testimony. You both testified on the same day. Professor Bamrah, I think I'll start with you since you were first up at the inquiry. I noticed you talked about, first of all, I have to say, I really loved how you opened your testimony. It was very, very charming. And those moments are rare at the inquiry where you talked about it being the anniversary of your having become a doctor. That was a really lovely moment. You talked a lot about representation and trust. And I wonder if you could tell us a little bit about your testimony that day.
Yeah, so, I've been in courts many times as medical director and providing, expert statements in my clinical work. But this was pretty nerve-wracking, because you realize that, the eyes of the world are on you. And I was representing the Federation, as you said, FEMO. And, to bring alive all the suffering over the last few years, it's awfully difficult, isn't it? You try and picture through that what our colleagues in the NHS went through and social sector is awfully difficult. It's very traumatizing. Many will have blotted it out of their memory, what happened. And you see colleagues who've suffered severely through COVID and are still suffering, and all those deaths, the moral injury from seeing patients die and not being able to grieve properly, which I'm sure you will come to afterwards. So I tried to bring life those examples, those stories that had really touched my heart. It was difficult, but quite an emotional thing to do. I have to say the team were amazing. Baroness Hallett and her legal counsel were absolutely amazing. They really were very understanding, very compassionate, because this is a very difficult subject, as you will know, and I'm so sorry for your loss, It's something that one has to live with, isn't it? It's so difficult.
Thank you for that. Yes, it's just something that has to be endured. There's no shortcut and no escape. I'm kind of jumping ahead in your testimony, but there was one thing because it interested me most, I have to be honest, and it's because my husband died in care. Therefore, to me, and I can say this because I'm a bereaved person, the health secretary at the time, Matt Hancock, is a particular villain. And I was very interesting when you testified that on the 27th of March, this was 4 days before 2020, 4 days before my husband died, you were one of a group of doctors who wrote to the health secretary pressing him to send instructions about PPE. And I don't know if you can talk about it, but I believe you took the health department to court because I don't know if they responded. Could you talk a little bit about that if you can?
Yeah, so we'd known that this was coming, That is the tragedy, that in United Kingdom, we knew this was coming. We knew that it was coming in December, not even in January, and so by March, we many of us were getting very twitched that there doesn't seem to be adequate protection. And as a previous medical director, I knew that there was a lot of emergency preparedness that you have to go through every year. And I was thinking, where is the preparedness for a pandemic that people were saying is going to hit us really hard? And that was the point where we wrote to Matt Hancock as a group from BAPIO, British Association of Physicians of Indian Origin, to say, look, hey, come on, where's the protection? They weren't listening to us. So we were approached by two GPs, Meenal Viz and her husband, Dr. Joshi, through their solicitors, Bindman solicitors, to say, look, we know you're interested in this matter. We are thinking of writing to the Secretary of State and taking them to court to say, where's the protection? So we joined hands with Bindman to say, look, Secretary of State, you've got to provide, we are holding you culpable, and you've got to provide how all frontline workers, not just doctors, all frontline workers with adequate equipment. Otherwise, obviously, people are going to die. They procrastinated and procrastinated. There was, this and that going on, because we know now that in the background, they were preparing all of this, getting PPE to the front line. And eventually they did. So eventually they said to us, look, we have managed to provide. So it served a purpose that we'd like to think that this would not have happened, even at the slow speed it did. It would not have happened had it not been for the court case that we embarked on.
Yes, I agree. It got through to the front line. I can tell you it did not get through to the care homes. Everything was seconded to the NHS. It's such a sore spot for me. Something else you testified about was a lot about, and this surprised me, that people were disciplined for wanting to protect themselves. And I wonder if you could talk about that a little bit.
Yeah, so there were a few people who were reprimanded or threatened with discipline. I don't know that anybody was actually disciplined, but they were threatened. That's enough, isn't it? Well, I have to say, not only was social care, but we also know that primary care didn't get the protection that primary care needed, and mental health services also were behind the curve in providing all that protective measures, all those protective things that were needed. Yes, so I think that eventually what had happened was that matters were getting out of control. People were dying right on the front line, and the first 10 deaths when they happened, that really set the alarms going for everybody.
Yes, I wonder, Nicola, if I could ask you what your main takeaway was from Professor Bamrah's testimony.
I think for me, it was when you said that you were being asked to risk your life and the lives of your family, and yet you had absolutely no confidence that your employers were doing anything to protect you in terms of providing that necessary PPE. I don't know whether you've had the chance to see evidence in previous weeks, Professor Bamrah. There was a GP who gave evidence by the name of Dr. Tilna Tilakumar, and she was I think she was coming towards the end of her training, and at the start of the pandemic, she was seconded to a psychiatric ward, I think, and she referred to how difficult it was for them to get PPE, even after there had been a COVID outbreak. And she referred to a visiting manager attending on the ward and physically ripping PPE off a colleague. And she mentioned that the visiting manager was white. and the person she ripped the PP off wasn't, and therefore would have been at greater risk. I don't know whether you saw that evidence, but for everyone who was listening, that was so shocking. And I would like to think that was rare, but perhaps you're going to tell me that it wasn't.
No, I did see the evidence. It was very moving, I was very touched, particularly as it's evident that she is still suffering, isn't she? She's suffering the psychological harm of the employer not protecting her or not able to protect her. And of course, yes, and I mentioned at the hearing in response to the earlier question about consultants and other people, nurses as well, being told that if they went anywhere near a PPE, they would be disciplined. People being told categorically. And the consultant I mentioned also was in a similar situation where she was told that she shouldn't wear any face mask, otherwise she'd be disciplined. She went on to caring for a COVID patient on the ward who died the subsequent day, and she caught COVID from him, she's pretty sure. And she went on to becoming very ill to the point where she was DNAR, which is not to be resuscitated twice. She was cared for very well. Eventually, she went to a different hospital. She was looked after very well. She was very complimentary because they saved her life, but she was at death's door at least twice. So that is very sad, isn't it? Because I think hopefully this will come out in the inquiry that not just, I mean, the NHS obviously has had quite a lot of space in this, but in social care sectors, I hope they've got as loud a voice, because they were completely deprived. As were GPs, I have to say, and so were mental health services, because the employer, it is regulation that the employer must protect the employees.
Thank you. And Dr. Finnis, this lack of PPE, I think, is particularly devastating to people who are immunocompromised. And I just wanted to thank you for coming to the inquiry. I know it must have been difficult and that you took a risk by doing that. And I just want you to know how much we appreciate it. I noticed in your testimony, and this is just me being stupid, they talked about clinically vulnerable and clinically extremely vulnerable. Is there a difference? What is the difference between these two, and does it impact on how they're treated?
Yeah, sure. Thank you. Just before I talk about that, if I may, can I just clarify, Nicola, how you introduced me? So I am medical doctor. I'm trained, worked for about 5 years, but I actually had to withdraw from face-to-face clinical practice way before the pandemic due to my severe immunosuppression. And since that, I now work still in the NHS, but in a non-face-to-face clinical role. So just to be absolutely clear about that, if I may. Yeah, so in terms of clinically vulnerable and clinically extremely vulnerable then. So clinically extremely vulnerable. So the first thing to say is that both of those terms were completely made up, if you like, by the government really at the start of the pandemic. And that although many of us knew that we had underlying conditions and we knew what they were, and maybe we were immunosuppressed through disease or treatment, or we had other illnesses such as asthmatics or diabetics, etc., we'd never obviously been put into groups such as clinically vulnerable, clinically extremely vulnerable before. In fact, the government only defined clinically extremely vulnerable. So that was what initially happened. Essentially, the clinically extremely vulnerable group, another name for them is the shielded. So they were the people who were designated the highest risk. And there was a very, I don't know if you saw in the evidence the list of the conditions that were decided. And those were decided on, we'd heard from Chris Whitty how that was decided. And it was just a kind of sort of a priori medical decision about, we think that these people are going to be high risk, a little bit from the evidence that was coming out of China. And so they had to make, I mean, I would say that they didn't make a decision in time, but nevertheless, the decision was quite late, actually, into March. And so those people that were clinically extremely vulnerable, they were, sent texts, written to, given emails telling them to shield initially for the first 12 weeks. The clinically vulnerable were never really defined. They were never written to or contacted to say, look, you've got an underlying condition that makes you higher risk. So, not necessarily the absolute highest risk, clinically extremely vulnerable, but nevertheless, still a substantially increased risk. The only way that clinically vulnerable people really knew they were at risk was the information coming out of the news. So, for example, you have an underlying condition, this person died sadly of an underlying condition of diabetes, this person was obese. We were hearing a lot of those kinds of things. And so people that had some of those conditions realized that they were at higher risk. People really only became aware that they were in this group called clinically vulnerable around the time of vaccination, when it became clear that some people, such as the flu group, so the people who are under 65 who are recommended to have the flu vaccine, they suddenly realised that they were also invited to have a more priority COVID vaccine as well in 2021. So I think it was really at that point that they realised that they were clinically vulnerable.
You talked about one of the main problems being this, and this has occurred in a lot of testimony, the lack of communication and the lack of guidance. And I was particularly struck because this was also a period of time for the bereaved that is significant. You talked about how shielding wasn't phased and how eat out to help out and happened. And I just wonder if you could talk about that in the experience, your experience and the experience of people in your group.
Yeah, sure. So that's right. So initially shielding, we were initially told 12 weeks, and then obviously that was extended, and in the end, was actually extended until the end of July 2021, 2020, beg your pardon. And that year, in that summer, obviously the rates had massively decreased. I think we're all aware of that. But people that had those high risk conditions or very high risk conditions still had them. We still hadn't been vaccinated in any way. Vaccination doesn't particularly work well for severely immunosuppressed people. But they still were high risk. And were they to still catch COVID, they still would be at high risk of death. But when shielding was stopped, there was no information about that to the people who had been high risk. There was no information about how to protect yourself. There was never any information about masks or how to wear them. There was never really information about modes of transmission. There was never any information to the rest of the population, if you like, about these people that are still high risk. And people were really left to fend for their own devices. It was ironic that Eat Out to Help Out actually happened at the same time, and it felt to people in CVF, they would say, it's a coincidence, but it felt like a horrible coincidence, because what happened, and we know that a lot of people who were clinically extremely vulnerable thought it's safe. I've been told not to shield any longer. Eat Out to Help Out, hey, there's a free meal. And I personally know people that were clinically extremely vulnerable that kind of believe that message, that shielding was over, they're no longer at risk. They went out to eat Out to Help Out, and subsequently, sadly, caught COVID.
Another topic that I know we want to talk about more in this podcast today, you mentioned DNA CPRs. I wonder if you could tell us about your testimony about that.
Yeah, so from the members within our group, and particularly those who were clinically extremely vulnerable or shielded, we have evidence from members that they were either telephoned. I can't get across the difficulty of that. So people, as I said, relatively young people in their 30s, 40s, and 50s who didn't have terminal or critical diseases, who were maybe just somebody that had someone like me, who has an underlying condition, but actually is, I'd like to think, a valuable part of society, working, a parent, active in the community. and suddenly a cold call from their GP asking them, do you want to be resuscitated? I, I can't underlie the impact that that's had on members of our group, and how it's left them feeling totally disenfranchised from society, sort of totally worthless, who not to save. That, I mean, that really is clear. There was then the other group. So that was the first group, and the second group, and this has continued to happen actually subsequent, and it continues to this day. People for whom have underlying conditions, so perhaps even the broader clinically vulnerable group, are finding that they have DNA CPRs written on their discharge letters. So obviously after you've been in an inpatient, day patient even procedure, or an inpatient, which is nothing to do with your potential to need a DNA CPR. It might be for a simple procedure that is nowhere near critical care, and you find that this has not been discussed, but you find it on your discharge summary in an envelope given to you that you open after you have left hospital. And I think one of the problems with that, or two problems, is that we don't know how many people it affects. There has been no systematic review of people who were particularly shielded, right? We've got that list. There is a shielded list. And CVF would strongly advocate for a recommendation from the inquiry to systematically review everybody's notes who were shielded. Do they have a DNA CPR on their notes? Is this what they want? Has anybody actually talked to them about this? And the second problem is, of course, mission creep, which is what Mr. Weatherby asked me. And there is actually an article that's within my evidence, that was actually in one of the newspapers at the time, or in 2022, I believe. And it was actually somebody that had atrial fibrillation, which is a relatively common arrhythmia of the heart, but it's not, again, something that's critical in the main, and can be easily treated. And what this lady found, that was because she had been shielded for another reason, which wasn't the relevant thing why she was going for her hospital admission for atrial fibrillation. When she turned up in A&E, they said, you've got a DNA CPR on your notes, we're not going to treat you.
Nicola, do you want to come in on that?
I'm sitting here with my jaw on the floor, shaking my head at just how shocking that is. And yet we've heard time and time again at how DNA CPR should not be confused with broader treatments. That's just appalling. Yeah, I'm so sorry for anyone who's experienced anything even approaching that. It's just to be told that almost we're not going to spend our valuable resources on trying to not even save your life, but just treat you, make you feel a bit better. That's very, very shocking.
I wonder if this is a good point to come on to Professor Wiley's testimony. This was Thursday. And I don't know. I mean, I'm reeling from this. It was so shocking to me to hear what testimony that he gave that was shocking, was that he confirmed that there was at least one NHS trust that had a policy of blanket DNA CPRs based on age, condition, and something else. I can't remember, but disability. Thank you. And this, to us, was so shocking, mostly because throughout this inquiry, we've heard witnesses say, no, there were none that I'm aware of, and all this kind of thing. And so this was such a shock that we were reeling. And I wonder if I could come to each of you and ask you what you thought about that. Professor Bamrah, I start with you.
It's quite shocking, isn't it? I mean, I think the mental effect of COVID right from the start was always on a back burner, you know, and the way that it was as if a section or sections of society were worthless. People who were elderly, who were decanted from hospitals, basically to die. You know, there were burial and cremation sites set up. I'm being a little dramatic, but maybe not, because, you know, these memories are going to be very vivid. Black and ethnic minority people, as Dr. Finnis was saying, who were immunocompromised. You know, there were sections of society who were made to feel that they were not worthy of saving. And we heard also about patients who were elderly being told, if a young person comes along, your intensive care bed and the ventilator would go to them rather than to you. You know, there were these kinds of instances that were going on. And so, look, I just hope that there will be very important things that the inquiry hopefully will focus on. And this would be one of them. And I mentioned to you a colleague who was told that she doesn't need resuscitation, but had it not been for her brother, who was a doctor, fighting to say, no, you are going to save my sister, because she was on her own. Had it not been for him, she would have been obviously not where she is today.
And Dr. Finnis, you referred to that message that Dominic Cummings famously scrawled on his whiteboard, "Who do we not save?" I wonder what you thought on hearing Professor Wiley's testimony.
Yeah, I mean, utterly shocking, but sadly not surprised. And certainly blanket DNA CPRs was something that we also wrote about within our statement, because we also strongly suspected, and indeed the CQC found that. So this is not even anecdotal. This is fact that this happened. If I can, I just want to also bring out, because it's not just DNA CPR, there was also this thing called the COVID-19 decision support aid or support tool, and that was discussed, I think, with the intensive care experts that returned this week. So we raised the COVID-19 decision support tool, not to be confused with the aid that was talked about by the ITU experts. The COVID-19 decision support tool did the rounds really early on in kind of April 2020, as I recall. It was all badged with the NHS written on it, and it was shared, I believe, with the Sun newspaper. It then did the rounds, as you might imagine, around the clinically extremely vulnerable, illness groups on Facebook or social media, charities, etc. Although we understand, although it's really not clear and it's really not come out of the inquiry yet whether this was ever really used. We've kind of been told that it wasn't really used. Then we were shown the COVID-19 decision support aid, which to all intents and purposes looked very similar to the COVID-19 decision support tool. And what that did is it actually gave points depending on your age, depending on your vulnerability. So depending on, for example, if you'd been an inpatient greater than 3 times, I believe, in the last year, I can't remember it exactly, you got 3 points. If you were then 50 to 59, you got 3 points. If you then had hypertension, you got a point. And those points added up, and over a certain level, there was a box underneath that then said what your ceiling of care was. The problem is, even if it wasn't, and something that we've repeatedly said in CVF is that even if that support tool wasn't actually used, and like I said, I'm not clear, if it wasn't used, the effect of that being put into the public domain and nobody publicly saying we're not using this, what would we be left thinking? We absolutely thought we would not be saved.
Yeah, I'm not surprised. I know in our group, COVID Bereaved Families for Justice, there was a lot of talk about this yesterday. I believe you issued a statement about it, Nicola.
Yes, we commented on it because it was just so shocking, but it seemed to be dealt with very, very quickly, and then almost put to the side. And I really wanted to make sure that it wasn't missed. Because I think the most frustrating thing to me was the witness who spoke about it He was from the Resuscitation Council. He said it was a member who brought it to his attention that this particular trust that he knew of was using blanket DNRs. The trust wasn't named, which obviously invites further question. Well, which was the trust? Was that a trust my loved one was in? Were they subjected to this? If it happened at this trust, why wouldn't it have happened at other trusts? And so the questions follow. But I think the most frustrating thing was that he said they issued a very strong statement that made it clear that blanket DNRs were not appropriate. But they didn't actually contact the trust concerned and say, what are you doing? Stop this right now. This is wrong. There was no, we need to report this to the HSE. We need to report this to the GMC. It was just, well, we put out a strongly worded statement. That seems shocking to me. And I don't know, Professor Bamrah, Dr. Finnis, whether you've ever come across anything like this, what the usual response should be to something like that.
It's not an unusual response, I'm afraid. That's how the NHS at a high level works, is, pick up the phone and say to the chief executive, look, either NHS England or the Secretary of State of Health should do that, really, to say, look, what's going on at your trust? I'm going to send you this, because you get millions of emails, you get a lot, and if you're chief executive, you also get a lot of instructions, but also, in something that is a matter of such grave concern and of such huge public interest, it's not acceptable that if they know a trust is, and it's all about accountability, and there was something I hesitated to say at the inquiry, but I nearly did actually, and I wish I had, which was that one of the medical directors was so stressed up about the whole thing, about the decisions and indecision at a higher level, that he said, we were being led by donkeys. That's how it felt, really, and to all of us, at the time during the first and second wave. And lessons from the first wave didn't seem to percolate into the second wave either. That was the other problem. So where is the NHS learning in all of this? I mean, we're a great institute. And I have to say the NHS is one of the best institutes in the world, but it has taken a bashing. It's taken an unnecessary bashing. The reputation of the NHS should not have been tarnished. It is the people who run the NHS that should be held accountable.
Yeah, I agree with you. And this issue of trust in the NHS, certainly among our group, I know just listening to the chatter you mentioned there, and this has always affected me badly, the fact that no lessons were learned between the first and second wave, and those of us who lost our loved ones in the first wave feel our sacrifice was for nothing, because it couldn't even go to save people in the second wave. And but even now, I find I'm a member, as Nicola said, of the COVID Memorial Wall. I maintain the wall with other volunteers, and we go into St. Thomas's to use their loo. And I always mask up when I go in, because there are vulnerable people in there. I don't know if I have COVID. This is the thing. I'm the only one. I kid you not, I'm the only one wearing a mask. I do not understand, and I've said this before, why in current medical situations we are not using these small mitigations at least to help stem the tide. Dr. Finnis, I'm sure you have some things to say.
Yeah, well, thank you for masking up. It's my first comment, Lorelei, because a kind of friend, I guess, of clinically vulnerable people. As I said during my evidence, it's this horrible term, personal responsibility, that is what it's come to. And actually that happened quite quickly, really, after Freedom Day, which was so early, wasn't it, now retrospectively? And then, of course, the kind of summarily dropping of face masks in healthcare to fanfare in summer 2022. for those of us that were clinically vulnerable or clinically extremely vulnerable, severely immunosuppressed, shielded, this whole group of people who amount to millions, by the way. So the shielded list was 3.9 million people by the end, and the clinically vulnerable list, I think it's something like in excess of 20 million. I mean, there's a lot of people for whom COVID is still a threat, either to their health in terms of long COVID, or of course still a threat to life. The fact that people who, like myself, I'm severely immunosuppressed, I find that every time I go into a hospital, and one of the really difficult things about clinically vulnerable people is that we have the underlying conditions, so we need healthcare. I mean, that's why we're clinically vulnerable, why we were identified, and so we're high users of healthcare, and it feels like Russian roulette every time we step through the doors. I wear the highest quality mask I can with the best fit. I take a CO2 monitor, but there's nothing I can do about it. So personal responsibility takes me only so far. And really, the organisation needs to protect people. So there needs to be better ventilation, HEPA filters that clean the air, mask in around. I mean, we would kind of advocate really for probably the whole hospital, to be honest, but at least in high volume and high risk areas. And of course, again, lateral flow testing. It's easy, isn't it? We've all done them by now, probably loads of them. Why are they not brought back into areas where people are at high risk? Or why are patients not tested when they arrive who appear to have a respiratory condition? Why are then people who are severely immunosuppressed or high risk put next to somebody that's COVID positive? And at the moment, we don't even know. We've had members who have been admitted through A&E into hospital as an inpatient for an absolutely necessary condition, who have worn an FFP3 throughout. I can't say how hard that is for people to do that, eating, drinking, because they know the area is not safe. There's no HEPA, the windows are glued shut. There's no understanding though, so you get gaslit potentially for wearing a mask, similar to what Professor Bamrah has been saying about his membership, the CVF membership. We get treated really badly. I mean, we've had people within the group be told, "Why are you wearing that?" by healthcare professionals. "Why are you wearing that? Take it off. You don't need to wear it anymore." "Oh, I've had COVID." In fact, I mean, just personally, I went to a medical appointment, and a doctor actually told me very proudly, "I've had COVID 4 times. What are you worrying about?" I mean, I don't know, that person's probably not immunocompromised, for example. It's really difficult now, and it does feel like, as I said during my evidence, the government guidance, which is there for a reason, it's actually the only thing we now have. And it's quite strict, it tells us to get somebody to do a lateral flow, wear a mask if they visit us, well ventilated space, not to go into busy indoor environments. And then what do we have? We have healthcare, which does none of those things.
Yeah, it baffles me, I have to say. I don't know, just as a general thing, it's like we're so keen to put this pandemic in our rearview mirror that we're refusing to face the kind of reality. And it's like it's become something else. It's become, I don't know what it is, political, or somehow we're putting our hands over our ears, la 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 la. It baffles me. I want to come back to each of you in a minute and ask you.
Can I just say something, sorry, about this, which is that I think the government at the time, I wrote about this in the BMJ with a colleague of mine, now deceased, Dr. Kailash Chand. We wrote about Freedom Day, you see, because that was a major worry. I think the government was pursuing a policy of mass infection because they firmly believed in herd immunity. I mean, I don't know if that can be proven, but I mean, it was mentioned by the government at some point that they believed in mass, herd immunity. Whilst that may or may not be true, you don't open up the doors to the virus so just suddenly, and it was letting a horse bolt out. So many of these policies, it's all about, there were policies where they didn't actually have any consideration to having, there was long enough time to have a consultation with the public, with us professionals. It just didn't seem to happen.
I remember that famously. It was the former prime minister, I believe, who said that. And that was before we had a vaccination with this herd immunity idea. Nicola?
Sorry, I just want to pick up on the masks issue. It's been very frustrating for me, so even more frustrating for our members to hear the back and forth about the advice on masks. On the one hand, it seems to be people on the front line saying, of course, we need the FFP3 masks. And then you have the likes of Professor Susan Hopkins, Dr. Lisa Ritchie, the CMOs all saying that the flimsy FRSMs are fine. And part of what they've used in their reasoning is that FFP3 masks are uncomfortable and they're a barrier to communication with your patients. And I just wanted to point out that, Dr. Finnis, when you gave evidence wearing a face mask. And at no point did anyone have any difficulty in understanding the evidence that you gave. And so this idea that it's a barrier to effective communication between a medical professional and their patient or their loved one, it just wasn't borne out, and you are the proof of that. And I just really wanted to highlight that because I think it's important. Because if anyone wasn't watching and just heard your evidence or saw a report of your evidence, they wouldn't necessarily know that you were wearing a mask when you gave evidence.
Thanks, Nicola. Yeah, I tell you, another barrier to communication is death. I just wanted to touch I'll come back to both of you in a minute, but we had a witness this week that I just found really interesting. This was the first time we had a witness giving evidence anonymously, who was a member of the Frontline Migrant Health Workers Group. It was impact evidence. She gave her evidence in Spanish. She had an interpreter. And I think it was really, she's a cleaner, I think, and it is really important, I think, to hear from workers like this. Mostly we hear from people of a certain stratum as regards their education, their jobs. We hear from consultants and doctors, nurses, politicians, and civil servants. But I think it is also important to get this broad experience. Hear these people who were just so crucial to the whole machine, were cogs in the machine. The machine would have ground to a halt without them. And they put themselves in the most incredible danger. And even now, my understanding is she gave her evidence anonymously because she's afraid of losing her job. They were put in terrible danger because they were afraid of losing their jobs. And I just wondered if any of you had any thoughts on her testimony. Dr. Finnis?
Yeah, thank you. No, I mean, I completely agree with you. And I think it was really meaningful actually to hear her evidence through her interpreter. Absolutely, the NHS only stands because of the people that are in it, full stop. And that's everybody that is in it, every cog, as you say. And cleaners, given what we're talking about, you know, an infectious pandemic, I know that fomites and touch and everything is less of a risk maybe than airborne spread, but nevertheless, that cleaning is absolutely vital. And of course, hospitals are places for not just COVID, but other superbugs as well. I thought that it was really interesting and worrying that she felt she had to, you know, give evidence anonymously. I really wonder what it is that makes people feel that about the culture of the NHS. I personally don't feel that I've had that experience, so I can't speak to it personally. But I understand that those feelings are real, and I think a lot of people feel it.
And Professor Bamrah, I think a lot of what this witness said echoed some of the things that you said about the fear among your colleagues and people you know.
It is true. And also, we're going to have a couple of witnesses who are going to be anonymous witnesses for that very reason. I don't know what point Bamrah Salat is going to call them, but and it is true, as Dr. Finnis said. What is it about the NHS that makes these people fear for their job? Something that they give their life to. It doesn't matter who they are. They could be doctors, nurses, cleaners. They still, some of them have a fear. They're only doing their job. And of course, we also hear that, and as people, Einstein said that famously, you don't learn from what you do well, you learn from your mistakes. And a wise man learns from other people's mistakes, or a wise woman. And we just don't have that culture. It's very unfortunate. Training classrooms, it works really well. On the shop floor, particularly during COVID, people were running scared, to be truthful. If you do this, this will happen.
May I ask you, because I know we have some time limitations today, so may I ask you each what, for any of your final thoughts, or perhaps what you wished you'd been asked, Dr. Finnis?
I suppose my final thoughts would be to really think about the group, the clinically vulnerable group, including the clinically extremely vulnerable, the severely immunosuppressed going forward, and what needs to happen really in response to the evidence that I gave and CVF's witness statement. One of the things that CVF would like to see happen is clinical vulnerability added to the equality group, because we're not necessarily exactly the same as the disabled group. We need protections too. During the pandemic, we were given a protection to work from home. The guidance that I spoke about, the government guidance, does speak about being able to work from home, but only within the confines of the Equality Act, which currently only talks about disability. Not everybody that has a clinical vulnerability to COVID would meet the threshold of the Equality Act. And that's something that we feel really strongly needs to be added to that law to protect people, to protect people's lives.
Thank you, Dr. Finnis. Professor Bamrah.
Yes, I had a lot of thoughts about this, but I think two things for the purposes of this conversation that I would like us to reflect on. The first thing is, I think there's something in the structure of Britain that needs to be corrected, because, all those people from ethnic minorities, the Black people who are dying and who have been unfairly treated over the years, something has to be done in the structure. The other, which is very germane to our conversation, is about those who've been bereaved, and the unresolved grief that they. I'm sorry to touch on this because this is very, very emotive and very, very possibly, I don't want to be insensitive about this. So, as a psychiatrist, I absolutely understand this. They will have unresolved grief. Many of them, over 200,000 people dying. It's just not acceptable. Of course, some were going to die, but not at the rate. It was like a Richter scale, just going an earthquake, just going up and up and up. One of my patients, she had bipolar disorder. Her husband looked after her for most of those years. She was a rapid cycling, had multiple admissions, and he caught COVID, and he died at a local hospital. Nobody could grieve. She couldn't go and visit him. He had 2 children. None of them could see him. They could not even say, the idea of not being able to say goodbye in a proper way, not to be able to bury or cremate your family in a proper way, I think it's, and also, those migrant workers who'd come here and their parents were dying back home, not being able to provide them with any care. They are carrying a lot of guilt about this, So I just can't emphasize that enough. It is really, and there's no return policy in this, isn't it? You can't go back in time and say, well, actually, look, let's reverse this and let's do it in a different way. So I really hope that, something strong comes out of this inquiry. I think we all are thinking that something will.
Thank you for saying that. You're right, there are no do-overs. It's a really large subject, and I believe in there are future modules that will deal with it. And you're right, I've never known grief like this. It's a very specific and new to me kind of grief. Nicola, may I come to you for your last thoughts?
I think more than anything, this week has demonstrated to me that if you are not part of a particular group, it's very easy for thoughts of them to not occur to you. So Monday we heard about pregnancy and maternity care and how midwives were redeployed elsewhere, but legally no one else can do the job of a midwife. And so pregnant women were really let down to the extent that we were told 7 out of 10 women who died either during pregnancy or shortly after giving birth, 7 out of 10 women, their outcomes could have been different had better care been provided. Women who didn't feel safe to go into hospital and so wanted to give birth at home, there was no home birthing teams available anymore because they'd all been redeployed. If you're not a woman who wants to wear a hijab, you don't understand the problems with PPE. If you're not a bearded man, you don't understand the problems with PPE which doesn't fit. If you're not a migrant worker, you don't understand that there's no one to go to say, they're not letting me wear PPE because you're scared you'll lose your job and then you're home and you're placed in the UK. If you're not clinically vulnerable, you don't understand how frightening it is to go to the GP to get the treatment that you need for your underlying condition. And no one's prepared to put their hand up because before the pandemic, as a group, you didn't exist. And so the government overlooked all of these separate, distinct groups with their own separate needs. And it was left to the people themselves to form collectives, to come together and raise their voice together in the hope of being heard. And that just isn't good enough. We need people in the government to either be capable of thinking about people that don't fit their narrow life experience, or even better would be to have a government that is representative of all forms of life, so that people who are disabled, people who are from the BAME community, people who are migrant workers, people who are clinically vulnerable are factored in at every part of everyday government.
Thank you for that, Nicola, for putting that so well. I think I'd like to finish with something that Professor Wiley said to his students when he was teaching them the importance of communicating well with families of the very ill or the dying. He said to them, everybody who survives will remember you forever. And that has really stayed with me because it's also true for the bereaved. We've survived and we'll remember forever, for good and ill. We're going to remember all the healthcare workers who used incredible resourcefulness, ingenuity, resilience to look after our loved ones. But we'll also remember those who abandoned us and betrayed us and lied to us. So I'd like to thank you both very much, Professor Bamrah and Dr. Finnis, for coming, and you as always, Nicola, for coming to talk to us today. Thank you so much. It means so much to the bereaved.
Thank you.
Thank you.
Thanks for listening to this instalment of the COVID Inquiry podcast. We hope you found it insightful and interesting. If you did, please rate us on the podcast platform you use and share the pod with friends and family who may value this type of commentary. We're looking forward to you joining us next week for more expert commentary, opinion, and insight into the COVID Inquiry evidential hearings.